The Pattaya City Expats Club is a non-profit social organisation and our speakers are volunteers. The club as such assumes no responsibility or liability for the professional reputation of or the quality of services provided by the speaker today.
This is a very important talk, of course. This is, our heart health and everything is an incredibly important thing, state of our heart. I'm talking about the state of our heart, and this is a very, very important topic, atrial fibrillation. Anybody ever had some heart murmurs, beats, irregularities? Yeah, I'm sure more people have had them than put their hand up. But anyway, I'm handing over to, by the way, how I first got to know Dr. Martyn was through his Facebook page before he moved to Pattaya, and he used to do medical bites. And he'd talk about his history with patients, and it was really fascinating. And how he guides them through the Thai medical system and beyond. And and anyway, I'm going to hand over to Dr. Martyn. He's a very entertaining, very bright, funny guy, and a very serious subject. So, round of applause for Dr. Martyn. This is about your 5th time, I think.
Good morning, everybody. Firstly, I'd like to say welcome to Gregory Sparks. He's the patient who came to see me about 4 weeks ago, wasn't it? First time. So this talk is based on 3 medical consultations that I had with him. And this is a complex case. Yet one simple question I asked Gregory alerted me to his real diagnosis. Yet, let's see if any of you, as I talk through this, can pick what that question was. I'll ask at the end. Anyway, there is a difference between coronary vascular disease and peripheral vascular disease. Would you agree with that? Don't know. Hardening of the arteries in the legs. So, do you think it's the same? Because it's an arterial system. The heart is part of an arterial system. Do you think that system's the same or different in the peripheral system, the legs and things, and the heart? Is it the same or different system? Not a hard question. Yes or no? Yes. Same system, but different outcome. Different outcome. And I'll explain why in a minute. Anyway, so in Australia, coronary vascular disease is known as, also known as coronary artery disease, affects an estimated 600,000 people, adults per year, and is responsible for 18,600 deaths. And it's the prominent cause of death in Australia. PV, peripheral vascular disease, affects about 20,000 people and 1,800 deaths per year from that. But it's all the same system, and it's fascinating. Okay, this is an artery. That's what it looks like. And the blood flows through the artery this way. And it's got this layer of small arterioles called vasa vasorum, which is Latin for vessels of the vessel. Now, that's interesting, well, I think. But here we have the formation of the heart, okay? And so you've got 2 vessels here, they're called the endocardial tubes, and this is day 20 of intrauterine life, day 20. So you get fusion at day 21, 22, 23, 24, and by 23 days, you can see that the arteries are starting to rotate, and they also fold back on in each other, okay? This is producing the heart, and there's the final heart after 35 days. Now, this is the mature heart, obviously. Now you've got the left main artery here and the right artery. Beautiful, isn't it? From that, I think it's fantastic. So, what's wrong with this picture here? There's nothing wrong with the picture, but what's the problem with it? No, the right and left don't communicate. That's why people die of heart attacks. And the older you get, because we're all older here, by the time you get to our age, the left and right, this is the right artery, and the left artery communicate. So you get joining of the arteries. So if you get a heart attack here, it's fed by the right side. If you get a heart attack here, it's fed by the left side. So that's the way you're protected. So people who are younger with heart attacks don't have this joining. All they have is a blockage of an artery which can't be supported. And that's why younger people die from this. Okay. So yes, the final thing is, these arteries here, which are supposed to look like that, these arteries here are the vasa vasorum. So these arteries that supply the arteries wall turn around and produce the left and right main arteries of the heart. And that's why it's different. That's why it's more susceptible to damage. And that's why people die from it. Do you understand what I'm saying? So these vasa vasorum, vessels of vessels, become vessels without vessels in them. They're just vessels and no lining with this supply, which is why the heart's vulnerable. Okay. So pulses, we're talking about atrial fibrillation. Atrial fibrillation is the most common tachyarrhythmia, which means fast heart rate, in 65, 70-year-olds. So a normal rhythm is about 60, 70 beats a minute. Okay? Now you can get an A rhythm there. An A. You just miss a beat. Okay. And then you can get a tachycardia, which is all the same. And then you get tachyarrhythmia. And then the last one is atrial fibrillation, which is this. It's totally unreliable. So it goes. It's all over the place. And that's why it can be a terminal illness, because the heart becomes insufficient. Okay. Any questions? Ask me questions, by the way.
Doctor, I just wanted to know how you test for these things.
How do you test? Put your ear to his chest, right?
Well, the atrial fibrillation is easy to check for because it's called irregular beat. Okay. So if you want to, you can use one of these watches that you can get fairly cheap if you want a basic rhythm, just to view it. But if you're going to use something to monitor your heart, then you better to pay a little bit more money and get something superior watch-wise. The other problem is, well, you'd actually feel the missed beat. You know, you'd be like this. What was that? I'm sure a lot of you had that feeling. But atrial fibrillation is very, very obvious because it's very fast and it's erratic. And that's what makes it dangerous. Okay.
My question is on CT scans, the calcium scan.
Yeah.
Will that help project, because it checks your calcium around your heart, your vessels in there. Does that help to tell you if maybe you're a potential at risk?
Yeah, well, the coronary calcium score is only going to show you how much calcification or load there is in an artery, either left or right arteries. And by the time that it's happened to people like us at our age, there's connection. I'll come to coronary calcium scores later, because I was going to discuss them in any case. Okay, this is electrical pulse. Okay, this is what it looks like on an ECG. So you've got the P wave. Okay, so the P wave, there. That, it's all about the P wave, what we're going to be talking about, by the way. So the P wave, this represents the depolarization of the atria, and which precedes the atrial contraction. So the pacemaker of the heart discharges, the muscles contract, and the impulse goes down to the ventricles, where you get another impulse, which makes the ventricles contract. So the QRS here is a rapid depolarization of the ventricles, leading to ventricular contraction. And the T wave, this at the end, is just when it's all depolarizing and needs to be repolarized for the next progression of the pulse. So here we go. It's a lovely picture, this. So you've got the these are the pacemakers. You've got a sinoatrial pacemaker there, and the atrioventricular one there, okay? So this is the normal rhythm, which you've just looked at, and this is how it works. So this depolarizes, this contracts, then the impulse goes to this one, the atrioventricular node, and it's passed to the left and right atrium, ventricles, sorry, there. And that's where a pulse comes from. Lovely, isn't it? Like that picture? I do. So there's something wrong with the picture, by the way. These are the pulmonary veins. There's only 2 there. There's actually 4. And this pacemaker has a wire going across to this one. So this causes this to contract. And this is atrial fibrillation. Chaos. Okay? No P waves. See, there's the P wave. It's all about the P wave. There's no P waves. So the electrical impulse is going all the time. And that's why it's erratic, because the pacemaker, this one in particular, is being driven by these pseudo electrical impulses caused by the atrial fibrillation. Okay, so this is what you do with atrial fibrillation. You have to you have to burn the inside of the atrium, the inside of the heart. Okay? Now, why does this happen as we get older? What's causing these areas to cause a stimulation to cause your heart to beat? Because it's inappropriate. Well, these 2 veins there and these 2 veins there, the cells in the veins actually can't decide whether they're vein cells or whether they're atrial cells. And so they become unstable when we get older. So, 60, 65, 70. This area becomes really unstable. So we go in there and we burn rings around here. So these cells can't confuse the system. And that's called ablation, or PVI, pulmonary vein isolation. So risk of stroke. Any idea what the risk of stroke is in atrial fibrillation? Sorry? Sorry? It's what? Oh, it's elevated, yeah. But any idea? It's not that much. You expect it to be more, but it's 2 to 5% per year, which is reasonable. But so you know we know what happens here. Do you know why you get strokes from atrial fibrillation? No. So what happens is the impulse from those aberrant cells causes the atrium, the top part of the heart here, to fibrillate. So it just flutters like this. It doesn't contract. It's like that all the time. And so you get pooling of the blood in this area here, and that clots. And then, heaven forbid, if you get cardioversion without checking for a thrombus, then the pulse as it comes through pushes the thrombus out and up into the carotid arteries, and into the internal carotid arteries into the brain. So this, as it goes through here, it causes temporary blindness in the eye. Anybody know what that's called? Amaurosis fugax. So if you're getting amaurosis fugax, you've either got hardening of the internal carotid artery or you're in atrial fibrillation. So if you find temporary blindness, it only lasts about 5 or 10 seconds, then get that investigated. Okay, so that was just the introduction. Now we get to the real stuff. So this, when Gregory first came to see me, this was about 4 weeks ago. I asked, this is what I do normally. So I take a full history. So I found about all his details, and I asked him my routine questions. First one is past medical history. What was your past medical history?
Hello, everybody. 10 years ago, diagnosed with atrial fibrillation. Lone paroxysmal atrial fibrillation. It wasn't bad enough even to have a blood thinner then, because everything it was a lone thing was happening on only atrial fibrillation every now and then, paroxysmally. So I didn't have to take drugs at that time, but you want to prompt me, but it slowly got worse, more frequent.
What is your story?
Oh, that was 10 years ago in Australia. I moved to Thailand 8 years ago. It continued to get worse until 3 years ago. It would have been, I would have been in AF most of the time. This manifested itself by extreme tiredness, no physical exertion went unpunished. And I consulted heart specialists here 5 years ago. Carried out a cardioversion, an electric shock, just 3 months ago. And so far, that's still holding.
Thank you. Now, what drugs were you taking?
A blood thinner and a heart regulator. That was...
Amiodarone.
Yes. Oh, yeah, blood pressure tablets, quite right.
Okay, so he'd been on amiodarone for 12 months?
Yes, more than 12, just over 12 months.
First question I asked him was, are you short of breath?
Yes, I got short of breath easily.
And how short of breath were you? Sometimes you're sitting there.
How short of breath were you? Any level of exertion would quickly... I could walk for 3 or 4 miles, no problem, but any extra exertion, dig a hole or cut down a tree, it was very, very quickly I was knackered.
At this stage, I stopped the consultation. Okay, he was on amiodarone, very dangerous drug. Side effects, pulmonary fibrosis, which is he was in the early stages of, which is why I had shortness of breath. I stopped the consultation because I had to treat him, because there was a degree of urgency here. 5 to 15% of people who take amiodarone have this consequence. It's called fibrosis, pulmonary fibrosis. So the heart becomes firm and stiff. Now, the cardiologist who was looking after him had been taking x-rays to make sure he wasn't getting cardiac pulmonary fibrosis. And he also looked at the thyroid, which is another side effect of this awful drug. And I listened to his chest, and I said, well, sorry, you're in pulmonary fibrosis. And I treated him immediately, massive doses of steroids. Both I gave you that day, and 2 to take home, plus tablets. Came a week later. How were you?
Well, a week later, Dr. Martyn told me he was about to get married, which which stopped me proposing to him. That was my intention.
You actually said that. I want to marry you.
Well, I felt so good. I mean, partly that was as Doc Martyn pointed out, the big doses of steroids. But no, I felt like a proper human being again, if I'd ever been one.
Okay, I'll just go through this quickly. This is such a dreadful... I've used this drug before on patients, and you don't give it for long periods because it's a level 3, which means very powerful anti-arrhythmic drug. Now, the side effects, unbelievable. So you've got pulmonary fibrosis, which is what he was getting. You've got microdeposits in the eyes. You've got blue colouring of the skin, which he didn't have. Liver toxicity, inflammation of the heart, myocarditis. Alpha receptor blockers, that doesn't matter about that. It causes hypotension. It causes neuropathy, numbness in the legs and arms, photosensitivity, and the thyroid. All those. And this poor chap had been on this for 12 months. On a what dose was it? He got you down to 200 eventually. What you?
No,
can't remember.
Can't remember what dose was. Sorry.
Yeah. I don't expect you to understand the technical stuff. It's yeah.
I'd written down when I first went to, before I first went to see Dr. Martyn, I'd written down all the things that had been bothering me, symptoms that I didn't think were related. I got as far as saying that I was on this nasty drug, and Dr. Martyn described the side effects. I didn't need to go through my list. Everything on my list was an effect of the drug. I was starting to get dizzy. I was staggering when I was, going off balance when I walked. Everything that's on that list of side effects, and they all disappeared in that first week, thanks to the steroids.
Thanks to the proposal. You're lucky you got back in, All right, so this is normal lungs, okay? That's what a normal lung looks like. Now, you could have 10-20% fibrosis on there and you wouldn't see it on X-ray because you can't see it because this is, it's not sensitive enough. But this is pulmonary fibrosis. That's what it looks like. Now, I didn't tell him, but if you get this, there's a 50% chance you're going to die because of that. Oh, what's wrong here? This is an ECG. What's wrong? Any idea? Sorry? Well, this is the, yeah, okay. Look at the pulse rate. 55. What's the pulse rate when you're in atrial fibrillation? Roughly 130, 140, 150. So this is what we call a rhythm strip, okay? And each 1, 2, 3, 4, 5, each one of these squares represents a fifth of a second. So all this confirms his heart rate of 55. A stress test. He was having his heart checked. So they did this, and the conclusion, normal stress test. Why not do, who was talking about it? Coronary calcium score. There you go. So he had a coronary calcium score. Remarkable, really good. See all that? A total calcium score of 9. Which is brilliant, which is next to nothing and very low. So they call this atrial flutter, but this is actually fibrillation with a slow response rate. So you see all these 1, 2, 3, 1, 2, 3, 1, 1, 2, 3. See them all? They're all flutter. They're all waves trying to turn the electrical impulse on for the heart to beat. That's what that is. And they shocked that out of him. So it looked like this. There. So that's not bad. But, see, his pulse rate, 62. When he was in flutter, his pulse rate was 53. The normal pulse rate's over 60. So he's got something wrong with his pacemaker. So I've written here, Gregory never suffered classical rapid response atrial fibrillation. Never. Okay? Because his pulse rate was always 60. And if you've got atrial fibrillation, free atrial fibrillation, from the atria, it's at least 100, if not 140 or 150. With slow ventricular response. Atrial fibrillation with slow ventricular response. So this is this is what he's got. This is his diagnosis. And I picked it up just by his pulse rate. You know, and if you've got fibrillation, it's not running at 55 or 60. Anyway, so the prevalence of atrial fibrillation with a slow ventricular response in the general population, because it's fairly new, is not established. And there are no large clinical trials investigating this treatment strategies. But it's likely to represent a subset of patients that have both inherent AV block and atrial fibrillation. That's exactly what this man's got. Atrioventricular block with AF. So, and this, which results in a delay or interruption of the transmission of electric impulses through the AV node. And it's caused by fibrosis and things. Ischemic heart disease accounts for 50% of all cases. It's also caused by cardiomyopathies, congenital heart disease, medication, beta blockers, and that dreadful amiodarone there. It's everywhere. So you be careful of amiodarone. And certain surgical interventions. The treatment, theophylline or atropine in the short term, because that'll slow the heart rate down. Or, sorry, it'll pick it up the other way. It's the other way around. Antiarrhythmic drugs, not amiodarone, but things like Tambacor and Sotalol. But what he needs is node ablation and pacemaker insertion. And that will give him a freedom which he's lost. It will give him exercise tolerance, which he's lost. So simply he requires ablation of his dysfunctional atrioventricular node and the installation of a pacemaker. Only thence will Gregory's heart be healthy, because it's not healthy at the moment. And you get tired quickly, don't you? Still?
No,
oh.
No, I can cycle 100k. No, I do always exercise, and since getting help from Dr Martyn, I've been able to exercise normally. I cycle about 25k a day, so which I wasn't able to do for a long time. But if I exert myself cutting a hedge, as I did a couple of days ago, I get pretty tired pretty quickly.
Okay, so that was pretty complicated. Any questions?
Can you please tell us, is there any specific to prevent this kind of disease? For example, like food or drinks?
Well, yes. Fizzy, sugary, just bad diets. What are you talking about? Are you talking about atrial fibrillation or just coronary artery disease? Or?
To prevent specific.
Well. Well, anything that starts clogging up your coronary arteries is a bad thing. And lifestyle is, who said that? Lifestyle's the big issue. You have to change. And you can't do it just incidentally, oh, I'll stop eating today or I'll change. You have to be rigorous in your diet restrictions. And I'm talking about real and good food now. I'm not talking about stuff from 7-Eleven, which is all processed. Absolutely no processed food. If you're going to eat rice, eat black or brown rice, not white rice. Cooking oils, use omega-3s. And if you want oils, so the the omega-3 oils. Two of the main ones are icosapentaenoic acid and dexohexaenoic acid. They're actually good and support your system well, okay? Because it's not, when you've got this problem, it's about healing the problem. The body always wants to heal itself. If you treat it properly, it will repair itself to its best advantage. The body doesn't want to die, okay? So, and the other thing is exercise. I mean, just everybody sits around and doing nothing. Exercise, get out and do something. Doesn't matter what you do, just do it. And then all the dietary advice, I mean, I haven't got time to go into all that, but, you know, antioxidants and things like that, because they cause cardiac damage.
Hi, Doc.
How are you?
Hey, let me see if I understand. All the great talk, by the way. And so I need to come to you, and then you send me to the hospital and have these tests done for my body, not his, for my body. And then I come back to you, and we decide what's good, what's bad, and what's ugly. Is that right?
Well, yeah. I mean, you know, I'm quite experienced in, and I know a lot. So I'm happy to give opinions, of course. I mean, I was in pain management, but pain management is everything. Because 85% of illness manifestation comes with pain. So I know a lot about this. So yes, the way to do it is get a second opinion. You were pulled up on this. You didn't know who to believe. Remember, you told me that. You didn't know whether to believe the cardiac surgeon or go back to Australia. But why did you take the easy route? Tell them.
I do feel a little silly in terms of boasting to family members back in Australia that I could walk into a hospital here, see, as I did on Monday, 2 or 3 specialists within a couple of hours, when it took back in Australia 2 or 3 weeks just to see your GP. So I was boastful of being able to have this affordable medical care here.
You talked about the correlation of the AF and the higher pulse rate, 130, something like that. Is that a constant pulse like that, or would it fluctuate?
When you're in atrial fibrillation, yes.
When he's in
When you're in atrial fibrillation.
But he could go in and out, or anybody could go in and out?
No. The clue for this chap, it was obvious, because when he was in atrial fibrillation and he had cardioversion or pulmonary vein isolation, call it whatever you like, his pulse was 60. And it should be at least 120, 140. And the pulse is called irregularly irregular, because that's exactly what it is. It's chaotic. And because it's chaotic, it's inefficient. And you can't work very well with an efficient heart. But his heart became efficient because his pulse was down at 60 all the time. So those little P waves I showed you, they weren't interfering with him, so he still had pulse at 60, and that would have been regular.
I remember my first EKG 1,000 years ago, and they told me that I had the irregular beat where it skips.
Yeah.
Okay.
Yeah.
And then they gave me the bill.
Yeah.
And that has been my history since age 76. They say, oh, look, there it is. See you later. Are they telling me the correct thing? Do I?
Well,
one last thing. I do suffer from fatigue and sometimes just unable to function for a day. And that's not alcohol or
Are we getting the truth here, or what?
Sometimes it's alcohol.
Sometimes.
So,
occasionally in the morning.
Occasionally, yes, occasionally. So my question is are they telling me the correct thing? Is that just something, oh, well, go on with your life, or do I re-examine that?
I'll tell you now. Can I come over?
You can come over now.
Oh, give me the other hand. You're not dropping a beat. You're dropping a beat occasionally. There, you just dropped it then. So that was 20 beats. Nothing wrong with that. Dropping beats at your age is okay. So that is the corrected device.
Now, sometimes my very beautiful acupuncturist does that, but it rises quite a bit. But I noticed for you, it just kind of.
You need. Who said that? That got to be an Australian, right? Brilliant.
Hi, Dr. Martyn. I have been to see you.
Yeah, I know.
With atrial fibrillation.
Yeah.
And you recommended Tambocor, actually.
Tambocor, yeah.
So a little bit of history for the guy back there. He said, how do you tell if you got it? Well, it did used to come up on my annual blood test, but I was always looking at the sugar. Every time they wrote AF on the graph, I didn't take any notice of it. Until one day, the Bangkok Paddy Hospital came here with a very big machine that was ultrasound, and it was testing the blood going up to the brain. And that's where he tested. I got a uneven heartbeat. But what they put me on is Xarelto.
Yeah, that's
I'm a bit frightened of taking these Tambocor drugs that you mentioned. I've mentioned it to the 2 or 3 doctors that I go and see about my heart, you know. Most of them tend to think that I'm on the right drugs because it thins the blood, which consequently I get marks on my hands and everything.
That's the Xarelto. Yeah. Are you still taking the Tambocor?
Still take the what?
The Tambocor.
The what?
Tambocor. Tambocor.
Bottom line.
The one you said you were
I gave you pronounce
Tambocor.
it differently, so I call it Tambocor. Yeah, right, okay. Sorry, I didn't understand your Australian accent. No, I'm not. No, I've never taken the Tambocor. And when I've asked my heart specialists, they say I'm doing the right thing, which is on the drugs to stop you having a stroke, basically.
Yeah.
They took me off other drugs that were blood thinners and put me on Xarelto. Yeah.
Well, that is a blood thinner.
Yeah, yes, it is, but I think it's more up to date than the one which I was taking, which was Plavix and that type.
And about 5 times the cost. And that's all right. That's okay if you're in atrial fibrillation. How old are you now?
80 now. Yeah.
So you're going to live to your 100, 110, probably. Okay.
Yeah, I'm all right with that.
No, so originally we wouldn't treat somebody at the age of 70 with anti-fibrillation drugs because they were old and they wouldn't get much advantage. But 70 is now old. That's old-fashioned. People are now living till they're 100, 110, 120. Now, you will if you're in atrial fibrillation without any cover, and this is why I gave you the Tambocor, to try and get you back into sinus rhythm, and you should have increased the dose, but you didn't. Oh, well, there you go.
They say, when I go back to them, they say, well, really, you're doing the right thing. No need to have an operation. The other one was an operation. Are you
talking about
which?
You haven't had pulmonary vein isolation. You haven't had PVI. Ablation.
Never had what, sorry?
Have you had the ablation or not?
No, I don't feel anything. I don't.
And what's your pulse rate?
I think it's about 70, something like that.
Yeah, that's not too bad. So all I was trying to do was settle your heart rate down to give you longevity. You know, as I say, at 70 before, we wouldn't have said, oh, well, he's going to die soon in any case. But we are going to survive. We are going to go on to 100. So you've got another 20 or 25 years, which will tire your heart. Do you understand what I'm trying to say? Is this on? Okay. So it'll there it is. So your heart will tire. Your heart will wear out because part of its function is inefficient. You have extra beats coming through. You're not in full atrial fibrillation, or are you?
No.
Because you're only at 70. Okay, so you've got it. Sorry?
Sorry, did you say I was only 70?
No, your pulse was 70.
Oh, 70 beats. Sorry, yeah. Getting it wrong, you know.
I know you're 80.
I can't hear very well either. You got any good hearing aids up there?
What I try to do is optimize the future for people to keep them as healthy as I possibly can for as long as possible. That's why I suggested it do it. The Thai doctors don't think like that, okay? And, Tambacor is 1,200 for 2 months supply. Or if you have an atrial fibrillation and you go in to have a pulmonary vein isolation, then you'll be $1 million baht out of pocket. I'm actually trying to save you money and give you good health.
Health is wealth.
Actually, I got kind of a question also, a couple of comments here. The gentleman here next to me just said, how do you know if you have something wrong? And I tell him, you go to the hospital and you get a complete physical done. I go to a hospital and I have that done. The complete physical was 7,100 baht. That's EKG, X-ray, blood, urine, CT scans, the whole bit. I have an abdominal aortic aneurysm. I've had it for 7+ years. I do a CT scan on that, which is relatively cheap. But to his question, how do you know? You go to the hospital, get a complete physical done. The hospital, like I say, I went to 7,100. If you want to know where it is, I'll tell you later. And if they see something they don't like, you go see a specialist right then and there. And you get a written exam results. So it's important that you go and get those examinations at our age, because we're not so much getting healthier, we're getting sicker. So you need to go have these examinations done and get checked out.
You're not necessarily getting sicker, you're getting older.
Well, getting older. And, I mean, before I turned 65, I had 1 surgery. I've had 7 since. Age comes and creeps up on you. So my thing is, my recommendation, go get a physical. The particular hospital I go to in December, they do a really good physical. A friend of mine from Australia was here last November, December. He was playing golf with a friend, went to bend over, and he just about ready fell over. Took him and got a complete physical. His PSA account was extremely high. It was tested in Australia, and it was high, and they did nothing.
Well,
they also did the CT calcium scan, and it was bad. So he went back to Australia. At first they were going to do stents, end up doing a quadruple bypass. He was on the golf course yesterday. So it's important that you go get a physical, get checked out. And as he said, as people tend to get older, they don't want to know.
Sorry, are you here to give medical advice or what?
No. I'm just saying.
Yeah, but you're wrong. I'm sorry, you're wrong. Okay. There is...
Just
sorry?
to hear his reply.
There is so much more to understanding health than X-rays and CTs and blood tests. And the majority of the blood test ratios here, they're relevant, the relevant, what's it called? Range, thank you. The relevant ranges are mostly wrong. They're out of date.
I want to say that it's surprising how many people don't know how to take their own pulse. The only tool you need is a fingertip. And a friend can teach you, for sure you can find out how to do it on YouTube. So anytime somebody feels something different from the usual, or you've exercised and you don't feel quite as usual, it's a good idea to just take your pulse. And if it's not regular, just take somebody's opinion on it. It's just a simple thing to keep in mind.
The other thing is you can buy on Lasada a sphygmomanometer, you know, take your blood pressure and it'll give you pulse at the same time. They're great and they're so cheap, it's ridiculous. So think about getting one of those. What, down here?
Hello, thank you for the presentation.
My pleasure.
I'm American. I was diagnosed in 2019. My doctor has put me on Eliquis and Metropolo. So I'd like your opinion about those medications. And also with the Metropolo, I feel dizzy at times, and also with my walking, I kind of serpentine.
So why did he put you on Metropolo? Blood pressure?
Yes.
Yeah. Well, it's slowing you right down for a start. So Metropolo not only slows the heart rate down, but it also slows the capacity of the heart to beat down, which is why you're feeling dizzy. So what dose are you on, 100 milligrams? Or 50?
The Eliquis is...
Oh, it doesn't matter about the Eliquis, that's a blood thinner.
Yeah.
That's not causing your problem.
It's, I think he's got me on 5
milligrams.
mgs, Metropolo.
Okay. Well, I'm not sure you need it. If you're dizzy and things, then there's something else going on. If you're not on 100 milligrams or 50 milligrams of beta blocker, metoprolol, and you're getting those symptoms, then there's something else wrong.
Okay, thank you.
My pleasure. So you can't.
We had an American doctor come through here en route to China, and he said, people asked him about tests. What kind of test do I need to get after 50, 60, or whatever? He said, look, your body's like a used car. It's going to get a little out of warranty as you get older. The problem with getting tested is the people are going to see that you're not falling within a range that they think is special for you. He said, I wouldn't get tested. He recommended maybe one test. He said, other than that, don't get tested because you won't find out stuff that you don't want to know. If you're feeling fine, good. If you're not feeling fine, then self-medicate. And if that doesn't work, then go see a doctor. And I thought his advice as a doctor was really appreciated by me because that's the way I thought as well.
Well, that comes from America, and it's very difficult to work through the American medical system. If you don't do the right thing, you don't get paid by Big Pharma. So it's distorted.
Just let me say this, and I'm sure the doc would agree with me. The one big exception to this is, especially if you grew up in Australia like me, regular skin cancer checks, okay? Because, you know, I had a melanoma cut out in the middle of my back 6 months ago. If that hadn't, I couldn't possibly spot it myself. And if that hadn't been cut out, the cancer would be eating into my spine probably. So really, I have somebody I recommend for skin cancer checks, Dr. Warraporn at Pattaya International Hospital. I've sent some people from here there, I think. And how good is she? Yeah, yeah. So yeah, go to see her regularly, and very, very important.
So for all you guys down here...
Yeah. What happened to me about 6 years ago, right? I went and saw I had a problem with my skin, and they reckoned it was sort of like skin cancer. Well, like, you know, you look at me and you think, no, I haven't got it. So anyway, I went to see this specialist, and what he did, you know, he said, right, I'll put you on steroids. Well, I didn't know what steroids were at all or anything like that. So anyway, when I went back home, I'd taken these, and he said, take these every day, I can't remember what the amount. And the next thing, I'm sat at the dining table with my daughter and my son-in-law, and I said, oh God, you know, I'm getting chest pains and that. I thought, what the hell's going on? And it just wouldn't go. So I went to the hospital. I live in Perth. Went to the hospital there. Within 5 minutes, they had me sat in a chair. They had an ECG on me. There was about 4 or 5 nurses and a doctor. That was within 10 minutes when I went to the hospital. And the doctor, I don't know whether it was a specialist or what, he said, throw them away.
Yeah. How long were you on them for?
Just overnight. Overnight, the next morning, they were checking me all night with, you know.
No, how long were you on the prednisone for?
It would have been only about 2 or 3 days.
Oh, that's all right.
Yeah.
No, well, you had a heart attack.
And the other thing is, I'm not saying anything different, but for appointments with doctors in Australia, I have no problem. I'm going back next month, and I can guarantee if I ring up where I go to see the doctor, I'll get an appointment within 2 days, 3 days. That's how good, I think, how good it is. That's in Perth, because there's a lot of medical centres with a lot of doctors in.
All right. Huge round. The doc will be around. You can ask some more questions. We're running a little bit long. We do have another short speaker. And thank you so much, Doc Martyn, for yet another amazing morning at the club. Stand up and come and get your, and you too, come on, stand up, certificate time. Doc Martyn with Gregory Sparks. Doc Martyn with Gregory Sparks. Come forward. Photo time, well done. Yay, thank you. By the way, I've sent some people to Doc Martyn at various stages for various things. We had a girl from Myanmar, she's involved in sales in Central Festival, and she had these big blotches on her face, okay? Not good when you're in sales. And the Thai medical system had given up on her. We don't know what you've got, we can't help you. Within about 2 minutes, Doc Martyn had diagnosed her. It was atopia.
Give me a chance.
And atopia is?
It's a familial sensitive skin, and it's caused by a shortage of gamma-linoleic acid in the skin. You give them gamma-linoleic acid, the skin fills out, and they get really itch.
And she was so grateful for me to taking her to Doc Martyn and the cure that she gave a present to my girlfriend instead of me. I don't know how that happened, but anyway. No, she wanted to express her gratitude. So, and many people I've sent to Doc Martyn are extremely grateful for his clarity and his thought. Wanted to share something, Doc?
Is Ken Lizzo here? No.
Who?
Ken.
Ken.
Ken and Neil McNulty.
Neil McNulty, are you here? Ken is here, but not Neil McNulty.
The money you sent me is going into the new program. I'm vaccinating, when I go out, 100 people with vitamin B, B1612, and folic acid, which is B9, because there's a deficiency here and people are getting sick because of that. So your money's gone to that.
Yeah. Now he's got this remote rescue Thailand thing, so if you want to help, which unfortunately involves diesel fuel at the moment, it's a bit of a worry. Yeah.
So we're up in Chayapum, and they were only giving 200, maximum 500 diesel out, and I turned up with my van. And because I've got a foundation, they filled the tank for me. I had to pay for it, but at least that's how I got back. So I just want to say something. This is something I wrote this morning, actually. Medicine is not about reading books and regurgitating facts. It's about assimilation.
Medicine is not about reading books and regurgitating facts. It's about assimilation. Only through assimilation is the beauty of medical wisdom realised. There you go. Yeah, no, it's always a delight having Doc Martyn here and visiting him. And the other thing is that when he goes up country, he's distributing, you know, clothes and shoes and stuff. So if you happen to be in a condo like I have, where people throw those perfectly good shoes and stuff out, I take him to Doc Martyn and he takes them up country to distribute them to the poor and stuff. So yeah, it's a really, really great service, this Remote Rescue Thailand. We're going to be collecting money outside on the way out. Okay, so you'll be able to make a donation on the way out. We don't pass donation things around in the actual meeting space. So yeah, no, he's been a great addition to our club and to the area, and by all means, go and get a second opinion from Doc Martyn. A very, very good idea.